Hi, everyone. Welcome to our Distinguished Speakers series. I am really excited to introduce you all to Dr. Fred Barrett. I first learned about Dr. Barrett's work maybe a couple of years ago. I think it was a recommendation from Adam. He said, you should talk to this guy. He's really cool and he does really cool research. I invited him to give a guest lecture in my class in my undergraduate class, Foundations in Addiction Science, last year, and it was like the best lecture. The students loved it. I loved it. I had so many questions. It was amazing. So I think Dr. Barrett has an interesting background. He got his bachelor's degree in music education and psychology, and then did his PhD in I'm on the wrong leg. Sorry. Okay, I'll just skip that for now. Did his what is your PhD? Cognitive neuroscience. Thank you. And so his research now is really kind of taking these two things and mixing them together and doing really cool stuff with music and with psychedelics, which is what he's going to be talking about today. So he received in 2017 an R03 grant which was the first federally funded research to administer a classic psychedelic to people with psychedelic effects as the primary focus, which is really exciting. And he's published really some of the first studies looking at psilocybin that look at the long-term effects of psilocybin months, years after the administration of psilocybin, which is just really cool. And the therapeutic potential for psychedelics is really high. And but I think there's a lot of limitations in terms of how much research you can do. And really, Dr. Barrett and his team have really been just pushing the field forward, opening up this whole new world of research and looking at psychedelics and the potential for psychedelics to serve as a therapeutic. So I am really excited to welcome Dr. Barrett. His talk is, I'm sure, going to be a really exciting one. We'll do questions at the end, and please join me in welcoming Dr. Barrett.
Thank you so much for the gracious introduction and the wonderful invitation to come here and share some of this work with you. I'm going to try to give you an overview of the field of psychedelic science as it is right now. So we're going to talk about the neuropsychopharmacology of psychedelic drugs. But let's start at the beginning. What is a psychedelic drug? If you look in the dictionary, you're going to see words such as sensory perception or perceptual distortion or hallucinations or strong feelings. And while these things may actually be true in some cases, they're not true in all cases with psychedelic experiences. And I'd argue that these are of the less interesting and less important aspects of psychedelic experiences. The word psychedelic was coined by a guy named Humphrey Osmond. He was an English-British psychiatrist who was expatriated to Canada. He was one of the first, if not the first person to administer LSD in a clinic in the 50s. He had a clinic in Saskatchewan where he was treating people with what we called at the time alcoholism, now we think of as alcohol use disorder. And he himself took LSD and psilocybin and mescaline and lots of other psychedelic drugs to get a better idea of how they worked, what it felt like, what was the space doing, and with the intention of hopefully understanding better how these compounds could be used therapeutically. He famously gave mescaline to Aldous Huxley, who's an infamous poet and philosopher who penned The Doors of Perception, based on the experience he had with mescaline that was given to him by Humphrey Osmond. If you haven't read The Doors of Perception, I suggest you read it. It's a very interesting read. But basically, Humphrey Osmond coined this term psychedelic, meaning psyche as in mind, delos as in manifest. He believed that psychedelic drugs manifested some unique aspect of the mind, gave people access to some aspect of their mind that they didn't typically have access to in some fashion. And he really thought that was what made psychedelics potentially therapeutically meaningful and relevant. We'll get into what that means a little later, but a little perspective on what drugs are psychedelic. And if you take the most broad and inclusive and permissive definition of psychedelic, well, I mean, what's not psychedelic? The coffee that I had this morning is probably psychedelic on one level, but that's not what we mean. There are lots of drugs, some of which are considered drugs of abuse or potential drugs of abuse, that people are calling psychedelic, including psilocybin, which comes from psychoactive fungi, mescaline, which comes from psychoactive cacti, drugs like LSD that are synthesized in laboratories. We also have ketamine and dextromethorphan, and salvinorin A, which is a very complicated drug, and ibogaine. Ibogaine is more complicated. Salvinorin A is not that complicated. But even MDMA and cannabinoids are considered psychedelic by some. But these are incredibly different drugs, chemically and in terms of molecular action in the brain. I'm going to be talking really only about classic psychedelic drugs. Even within the kind of umbrella, the smaller umbrella of classic psychedelic drugs, there are lots of different pharmacological classes. There are tryptamines, including psilocybin, which has fungal sources, DMT, which has plant sources, phenethylamines like mescaline, which has cacti plant sources, and laboratory drugs like 2CB, ergotamines like LSD or the naturally available LSA. Among all of these different pharmacological classes, these drugs typically share the property of having affinity for the serotonin 2A receptor. They have the ignoble commonality of being most of them are Schedule I compounds. We're going to really focus most in on psilocybin, which has the lion's share of current contemporary evidence for any signal for potential therapeutic efficacy. And also, most of the data are built up around psilocybin or LSD. There are risks to psychedelic drug administration, and we're going to review those. So they basically break down into physiological and psychological risks. Classic psychedelic drugs, especially psilocybin, are known to have a dose-dependent, modest but somewhat reliable increase in blood pressure and heart rate. We see here on the side a chart adapted from one of our studies, where as you increase dose, you also increase. I don't know where this pointer is. I'm sorry. So as you increase dose, you increase systolic and diastolic blood pressure on average. These are averages, and the averages are not too alarming, but people can have much larger increases in systolic and diastolic blood pressure, also heart rate. So one of the first things that we screen for are cardiac abnormalities, not because we know that there's a specific vulnerability from classic psychedelics like psilocybin, but in the general case, if you stress the cardiac system, then you can uncover illness or other cardiac events. We don't want to do that. So after considering heart rate and blood pressure, there are a number of acute physiological effects that you can consider, adverse effects that are well known and described, like dizziness, weakness, tremors, nausea, drowsiness, and other things that are dose dependent and time limited to the time course of subjective effects of the drug. There is a notion or some evidence that specific exemplars within the classic psychedelic drug family may put people at risk for serotonin syndrome. LSD apparently is unique in that aspect, and some psychedelic experiences are encountered after taking admixtures like ayahuasca. Ayahuasca is essentially a plant source of dimethyltryptamine mixed with monoamine oxidase inhibitors and a couple of other compounds. And when you have monoamine oxidase inhibitors on board, as well as something that's serotonergically stimulating, that can increase your risk for serotonin syndrome. All of those things aside, really, to the best of our knowledge, psilocybin and LSD and other classic psychedelic drugs don't really have other known physiological risks. They're rather relatively safe physiologically up to incredibly high doses. The real risks that we try to mitigate after careful screening are psychological risks. These experiences can be incredibly powerful. The strength of the subjective effect is dose dependent and time limited to the typical time course of drug effects, but people can encounter some really distressing experiences, including but not limited to feelings of paranoia or fear or grief or panic, sensory disturbances, feelings of physiological disturbances that are extra challenging under this very vulnerable state that people find themselves in. And everything that I've been talking about right now, when I use the word relatively safe, I mean in incredibly controlled circumstances. There are additional risks to psychedelic drug use in uncontrolled settings. We've conducted a series of surveys of people who reported having bad trips, if you will, or challenging experiences with psilocybin specifically. But I think the findings could generalize to other classic psychedelics. at a non-zero rate for sure. Out of almost 2,000 people in our first study, roughly 11% of people said that at some point during their challenging experience or bad trip, they put themselves or others at risk of physical harm. Over 6% of people experienced some form of distress that led them to find professional psychological or psychiatric help after the experience. And I think 2 to 3% of people reported actually, showing up at the emergency department because they needed help, and that's the only way they could find help with their kind of acute psychedelic experience. So there are clear risks in uncontrolled settings, but we feel that in controlled settings for very carefully screened individuals, that these can be well-managed experiences. So current best practices for research administration of psychedelic drugs included the careful screening that I mentioned, including not only screening for those with cardiovascular risk, but also screening for those with a personal or family history of psychosis or bipolar disorder. And one of the reasons for that is, kind of taps back to the history of the thought around the research and clinical use of psychedelics. In the 50s and 60s, there were a lot of people that believed that psychedelics were psychotomimetic, or they mimicked, kind of psychosis-like state, which itself was really interesting. People got really excited at the potential of having a pharmacological model of psychosis that could then be used for studying the etiology of the disorder and then treatment. Humphrey Osmond himself, if I'm not mistaken, went as far as saying that psychiatrists in training should be given LSD so that they could better understand and have access to that experience, and then be better equipped to treat their patients. Of course, that's not happening, and that never did quite happen. But it really gives you some insight into the way that people were thinking about the subjective effects of these drugs at that time. It may go without saying, but I'm going to say it anyway, that a lot of people began to think, well, if these compounds can mimic psychosis, maybe we should be careful about administering them to people who are at risk for psychosis. That general sentiment, along with a couple of other pieces of information, one that was a survey that was published by Sidney Cohen at UCLA in 1960. He sent surveys. I always want to say he emailed surveys. No, he snail-mailed surveys, of course, in 1960. Before that, to everyone that he knew who was doing clinical research with psychedelic drugs, and asked a number of questions, including but not limited to, how many patients have you treated with LSD or another psychedelic? How many of those individuals had a psychosis-like reaction, and how many of those kind of psychiatrically meaningful reactions lasted more than 72 hours? And so, caveats abound. He received responses from less than half of the people that he sent the survey to, so we don't know what those missing data would have represented. Of the responses that were returned to him, I don't believe any of them really tracked patients for longer than a week after a given LSD administration. But of the responses that he received, I believe they represented about 25,000 LSD administrations to over 5,000 individuals, which is a massive amount of information. And of those, he noted 3 cases of a reported psychiatrically meaningful experience that lasted for longer than 72 hours. The first of those was in a patient who was suffering from schizophrenia, who was institutionalized, and who was receiving many large doses of LSD. The second person had an identical twin who had schizophrenia, and the third person had a sibling who was not an identical twin who had schizophrenia. And we know enough about the heritability of schizophrenia to start to kind of draw lines between those things. All of this and some other data that popped up in the literature after that really kind of leads us to be very careful about that question. Maybe it's an important question to ask, but maybe we're not at the right time to ask it, and it will be very ethically challenging to try to approach that in an empirical study. So we're not answering that question yet, and we're basically carefully screening people out for personal or family risk of psychosis or bipolar 1 disorder for sure. And then we get to contraindicated medications. We have a lot of clinical trials that are going on that include people who are suffering from depression or other related disorders, and many of them are on SSRIs. And to date, nearly everybody is excluding people who are currently maintained on SSRIs or other serotonergic drugs, not because we necessarily think it's a medical risk issue, but there's kind of anecdotal evidence and suggestion that people who are maintained on SSRIs may have a blunted response to psychedelic drugs. And that's something that a couple people are now beginning to get into empirically, but that hasn't really been fleshed out yet. Okay, so after people are carefully screened, we go into a preparation phase where a participant or a patient is paired with two trained clinicians or study facilitators who go through 6 to 8 hours of preparation that includes rapport building. We ask people to tell us their life story from the very beginning, all the highlights and the lowlights, and just so that we know who you are. And just that process itself can go a long way to building rapport and trust. We also tell people as best we can all of the things, good and bad, that they may encounter. We impart the fact that we don't know exactly what's going to happen to any particular individual internally, psychologically on any given drug administration session, but we will be here with you the entire time to support you, monitor your blood pressure, make sure everything's okay. And in clinical studies, oftentimes that period can include structured or unstructured counseling or therapy, psychotherapy. So it's really interesting. The clinical trials that have been conducted in tobacco use disorder and alcohol use disorder have embedded psilocybin administration days within a structured course of CBT or motivational enhancement therapy or something like that, whereas the clinical trials that have been conducted so far with patients with mood disorders haven't had any real structured psychotherapy, but unstructured psychotherapy for sure. We'll get into that later. Okay, so screening, preparation, then we have our drug administration day. Participants come in early in the morning, they do some initial assessments. We administer a capsule containing psilocybin or something else if it's a controlled study. And we have people lie down on a couch, tucked in a warm blanket with eye shades and headphones, listening to a pre-selected playlist of primarily Western art music in a comfortably appointed room. This doesn't look like a clinic or a hospital bed. This is, more like a comfortable, living room in your maybe slightly hippie uncle or aunt's house. But this is not a real session. This is just kind of a mock session, but this is where we ask participants to occupy all day. The time course of drug effects can last about 4 to 6 hours. And during that time, if patients or participants get into a challenging kind of psychological space, we hold their hand, we reassure them, we talk them through it, and with that kind of minimal intervention, we've gotten just about everybody through this experience. At the end of the day, we debrief briefly, and we then kind of hand off the participant into the arms of someone who will take responsibility for them, get them home safely, make sure they're okay. And the next day, people will come back with some form of written description of what happened from their perspective. And then we'll enter into a process whereby we walk through what happened during the day. We can compare notes, and we begin to talk to the participant and help them try to understand what happened and integrate it into their lives so they can move forward. That's it. That's what psychedelic therapy with the classic psychedelic drug is. Psilocybin therapy, LSD assisted therapy. That's basically what it is. And so we've talked a little bit about some of the psychological, physiological risks, what the package looks like. A really reasonable question to ask that's often asked early on in these talks is, well, great, fine, but I mean, is this not a substance of concern? Does this, the psychedelics have abuse liability? And we have a lot of methods that we use as a field to try to understand whether, especially novel compounds, have abuse liability. What is the abuse liability of a compound, known or unknown? Some of the assays that we'll kind of try to use here to answer that question include self-administration assays, especially in animal models. Can we get an animal to self-administer this compound? And frankly, there have been a lot of attempts. A colleague, William Fanagrossi, in 2004 published a study in which he had to bend over backwards to trick primates into self-administering classic psychedelics. And he was able to do it, kind of, but nothing that's really been done really kind of lines up with or is similar to the type of self-administration that you can find in an animal model of cocaine use or methamphetamine use or something like that. And drug substitution is another assay that we can use to ascertain abuse liability. Psychedelics don't substitute for other typical drug classes. The Addiction Research Center inventory is a questionnaire that contains a number of different dimensions of experience. It's really a questionnaire that is meant to capture the subjective effects of a drug experience. And they have a number of different dimensions, amphetamine-like or sedative-like, et cetera, et cetera. There is an LSD scale. The LSD scale is really mainly consist of dysphoric effects and that are expected to limit the abuse liability of drugs that score highly on that scale. So that should tell you something. Finally, there's really no known withdrawal symptom or craving symptom that typically results from use of classic psychedelic drugs. And people who do use classic psychedelic drugs a lot don't typically exhibit compulsive drug seeking in the same way that they do for other drugs of abuse. It's very clear that some people do meet criteria for substance use disorder as applied to hallucinogens. So I don't want you to walk away from this thinking that, oh, there's absolutely nothing to see here. But in the typical use case, in the typical individuals who are exposed to these compounds, there is not abuse liability in the same way that we see abuse liability for other common drugs of abuse. So what do these compounds do? When you hear the word psychedelic or hallucinogen, a lot of people often think of sensory perceptual effects, visual distortions, hues, brightness, edges being more salient or rich, or illusory movement or geometric or kaleidoscopic imagery overlaid on your visual field. Yeah, this stuff kind of happens. It'll happen in a lot of people who have psychedelic experience, but it certainly doesn't happen with everybody. And like I've said before, I think it's of the less interesting kind of acute effects of these compounds. There are effects on perception in many people. There are also effects of psychedelics acutely on cognition. So I conducted a study in which we administered over a course of 5 drug administration sessions, placebo, a very high dose of dextromethorphan as an active control, and then increasing doses of psilocybin. We looked at a number of different, we had participants complete a battery of kind of neurocognitive tests during each of these drug sessions. At baseline and then 2 hours after capsule administration, we had people complete the digit symbol substitution task, which is not a process pure task, but it does involve and require some elements of working memory, attention, and executive control. And so the task here is that you see an array of symbols at the top of the screen, and then right below that an array of numbers, and then you see a single symbol one at a time in the center of the screen. And your job is to press the button on the keyboard, the number that aligns with the symbol. And one of the outcome measures for this task is the number of trials completed within 90 seconds. Another outcome is the accuracy, the percent correct among those trials that you did attempt. And then at the end of those 90 seconds, the array at the top goes away and you're just presented with symbols one at a time, and you're supposed to remember which number went with which symbol. And so we actually see a dose-dependent decrease in the number of trials attempted with psilocybin, but we see no decrement of accuracy, which is very interesting to me. That kind of suggests to me a classic speed accuracy trade-off. People are not necessarily unable to execute the cognitive processes that are needed to complete the trial. They're just slower at it. Maybe they're slowing down in order to maintain that accuracy, or maybe there's just some generalized psychomotor slowing that is accompanying this. But this doesn't look to me like an impairment of executive function or the other processes necessary to complete this task. What's interesting is there's a double dissociation here, whereby we do see a reduction in number attempted and accuracy under the high dose of dextromethorphan condition. But where we do see an effect of psilocybin is a dose-dependent decrease in that substitution recall, or the associative learning that is necessary to complete the task at the end where the array goes away. So interesting dissociation of effects, some preserved cognitive function and some impaired cognitive function under the effects of psilocybin. Briefly, we see something interesting with the letter MBAC task, which again is not a process pure task of working memory, but it is related to working memory. Who here is familiar with the task? Okay, so essentially in this task, you have 3 conditions. In the zero back condition, it's almost like a response inhibition task. When you see one letter on the screen at a time, and whenever you see an X, you press a button. And that's the zero back condition. And it's rather easy. In the one back condition, you press a button whenever the letter on the screen is the same as the letter that came before it, or the letter that's one back. And in the 2 back condition, which is actually rather challenging for a healthy, normal adult, if I can consider myself that, you press a button when the letter on the screen is the same as the one that's 2 back from it, right? And so we can compare here the white bars, which are the zero back task at each of these time points, or at 2 hours post-drug, and the 2 back task, which is very difficult. And so we see actually impairment, a dose-dependent impairment of working memory as is required for the 2 back task. reflected in a reduction in discriminability, but also a kind of response bias becomes a lot more conservative, and the response time increases. This is another interesting double dissociation where we see a dose-dependent effect of psilocybin on this process, but not dextromethorphan, right? So executive function possibly maintained, associative learning and working memory possibly impaired with psilocybin. And we also conducted an episodic memory task. So we had participants at about 1.5, 2 hours in, try to memorize a list of words. And then 6 hours later, after the drug effects subsided, we asked them to, recall, just say, hey, tell me all the words you remember. And actually that recall process, is it not here? Well, okay, so believe me, the recall showed a dose-dependent decrement. Sorry for not including that here, but essentially, when you then challenge the participant, put one word on the screen at a time and say, do you remember seeing this word? How about this word? How about this word? That there's actually, no decrement in episodic memory recognition, and there is a decrement from dextromethorphan. So what do we have here? We have selective impairment of certain cognitive processes, certainly not evidence for global disengagement from the tasks or global cognitive impairment. We also did the mini mental state exam at 2 hours post-capsule, which is right about the peak effects, and we saw absolutely no decrement in the mini mental. So no evidence of delirium either. This is not dissociative. This is not delirium inducing. This is something else, right? So we've talked about perception. We've talked about cognition. What else is going on? Well, we have to spend a little bit of time to talk about other strong, peculiar, possibly profound experiences that people report. And these may come up, these are going to come up a little later. So there's something really kind of unique that the field so far has struggled to kind of wrap language around. Some have called this ego dissolution, and I personally have difficulty appealing to psychodynamic theory to try to explain this. That doesn't mean it's wrong, it's just my hang up. But it has a certain kind of heuristic sense to it. Whatever you think of as a sense of self, people report seeming to kind of go away for a time or dissolving. This is language that people can understand, and it kind of reflects what people are reporting. The model that we've adopted at Hopkins is that of a mystical experience, and I'll be the first to admit that maybe there's a failure in marketing there, and there are equally challenging problems with calling these things a mystical experience, but we have operationalized it to a certain extent based on the work that was done in the philosophy of religion and also the psychology of religion and spiritual experiences, beginning all the way back 100 years ago or more with William James's work on the varieties of religious experiences. And so these states, as described as a mystical experience, involve primarily a sense of unity or oneness with something, maybe your environment, the people around you, the world around you, the universe, really kind of focusing in on a breakdown of the boundary between self and other. And there are a few other words here, but really what we found in follow-up psychometric analyses of our questionnaires that we use to try to quantify these things, and you can't be a good psychologist without a questionnaire, right? Is that deeply felt sense of positive mood, transcendence of time and space, or sense of time and space kind of breaking down, and curiously ineffability or the inability to put these experiences in words. This seems to be above and beyond, possibly not completely captured by simply cataloging disturbances in perception or cognitive deficits that may or may not occur during the acute effects of these drugs. So what have we kind of covered in a broad sense? Psychedelics can lead to changes in perception, selective impairment of certain cognitive processes, and intense subjective experiences that you might want to consider under the blanket term peak experiences. There are some models of neurobiological circuits and the way these circuits may be kind of changing in support of or in response to these wild experiences. So I'll just briefly run you through these models. One of them is the corticostriatal thalamocortical circuit model. What you have to understand about this model is that it focuses in on the thalamus as a bit of a sensory filter. And in this circuit, this is a well-described circuit outside of psychedelic science. And with this circuit, you can think of the thalamus as almost like a switchboard for sensory information, deciding what will be sent forth to cortex for further processing. Almost every sensory modality flows through the thalamus to get to cortex. The only one that doesn't is olfactory sense organs. There are like 1 or 2 synapses between your olfactory epithelium and piriform cortex. Everything else flows through the thalamus. And in an awake, alive, typically functioning human being, We can't attend to all of the sensory stimuli that are bombarding us at every moment, but there's kind of reciprocal relationship between the thalamus and mostly prefrontal cortex in order to kind of help regulate this flow of sensory information. And the theory goes that psychedelics, as serotonin 2A receptor agonists, and given that serotonin 2A receptors are densely expressed in the thalamus and the prefrontal cortex in some striatal areas that are part of the circuit, somehow disrupt the circuit. They disrupt the filtering process. And we're not exactly sure where this occurs to begin with. It may be that the 2A receptor agonism in the thalamus begins to break down thalamic projections that are used to help in this reciprocal kind of feedback. It's probably more likely that the prefrontal serotonin 2A receptors agonism is leading to the breakdown of the circuit. But essentially, you have 2A agonism that disrupts the circuit. More sensory information gets to the cortex than is expected. That further breaks down this reciprocal kind of filtering, and then all of a sudden the cortex is kind of overwhelmed, and that leads to everything else that happens, right? That's the corticostriatal-thalamocortical circuit model, in brief, at a high level. And it's interesting because this model was also kind of implicated in some disturbances that may occur in patients who are suffering from psychosis. I'm not going to go into that, but it's an interesting kind of connection back, and maybe one of the reasons that this model was applied to psychedelics. There's also the claustrocortical circuit model. The claustrum, until recently, was very difficult to study, but I'm going to get to that in a minute. Let me just show you, we've done a couple studies very recently demonstrating that not only is there a disruption of thalamic connectivity to cortex and thalamic connectivity within the thalamus, intrathalamic connectivity during psychedelic experiences, but we can actually localize this disruption of thalamic connectivity to the medial pulvinar nucleus of the thalamus and the medial dorsal nucleus of the thalamus. The thalamus is not one unitary structure. It's a collection of lots of different subnuclei that each have their own specific connectivity to different areas of cortex and their own kind of unique kind of relationship to sensory and cognitive functioning. And the pulvinar and medial dorsal nucleus are two of the three thalamic nuclei that have a dense expression of serotonin 2A receptors. It turns out that psilocybin seems to selectively reduce the intrathalamic connectivity of those nuclei, and also connectivity of those nuclei to occipital pole, which is basically, contains visual processing areas, and the default mode network, which is highly implicated in certain aspects of psychedelic experience. So we're not only seeing involvement of the thalamus, but specific involvement of thalamic nuclei that are proposed to be particularly vulnerable, maybe, or susceptible to psychedelic influence. And there are a number of other thalamus studies. I can send you citations if you'd like, but that's just to kind of hit on one aspect of this. So there is basically some preclinical and some human evidence that psychedelics selectively impair these thalamocortical circuits. Moving on, the claustrum is, if you're looking from the top of someone's brain at a slice right across the middle, you can see the claustrum is this thin green slice in both hemispheres, tucked away really almost in the center of each hemisphere, neatly behind the insula and between the insula and the putamen. It's been very difficult to study until recently because it's so small and it's so hard to get to. But it's a very interesting area. It was proposed by Francis Crick of DNA fame and Christoph Koch, a rather famous neuroscientist, in 2005, and what I believe may have been Francis Crick's final academic publication, that what we know about the claustrum, we knew at that point, was that the claustrum was one of the most densely interconnected brain regions to all areas of the cortex. And they suggested, well, if there were to be one brain region that was necessary for stitching together multimodal sensory information, percept, and decision-making and action, to create the seamless perceptive being that we all experience, right? The claustrum would be a great candidate because it's connected to everything. It would be one of the most well-positioned brain regions to do this for a lot of reasons. And they thought, well, maybe the claustrum is like the conductor of consciousness. It's conducting consciousness by stitching all these things together seamlessly so that we can interact in the world. Turns out the claustrum is probably not the conductor of consciousness that Crick and Koch thought it was. If there were a brain structure that were doing that stitching together seamlessly, constantly throughout time, it would be a brain region that's constantly active and awake, alive, and behaving mammals. And it turns out it's really not. It's only transiently active. But it's very interesting to us, not only because of implications of consciousness, but because a brain region that very highly expresses serotonin 2A receptors, as well as other receptors like kappa opioid receptors that are targeted by atypical hallucinogens like salvinorin A. Importantly, in a pretty important paper, Chuck Nichols and Nichols and Martin identified through this sophisticated cell sorting technique prefrontal neurons that initially responded to the drug DOI, which is a standard psychedelic drug used in animal research. And they found that 50% of those prefrontal neurons that initially responded to DOI in the kind of evolution of the psychedelic experience, 50% of them were claustral afferents. So really heavily implicating the claustrum and the initial effects of psychedelic drugs. We conducted the first in-human study of claustrum activity using MRI methods. I won't bore you with all the gory details, but it's suffice it to say we identified that at the onset of difficult trials in a task, a block of difficult trials, that's when we saw the onset of claustrum activity transiently. And we believe that claustrum may be involved in essentially helping to regulate brain state space. So helping to, when you have to switch from one brain state space to another brain state space in order to respond to a change in the environment or more challenging conditions, the claustrum comes on to kind of disrupt the current brain states and then instantiate the next brain state. And so with all of that information, you know, we asked the question, can we detect any changes in claustrum function during the effects of psilocybin? And not only did we see a reduction in claustrum activity during psilocybin effects, we also saw a reduction in claustrum connectivity to task control, attention, and default mode networks, which is really fascinating. It could be that psychedelics have their initial kind of change of brain state because they take the claustrum out of the equation. And without the claustrum online to help manage and regulate brain state space, that brain state space may just become an awful lot more disorganized, which could lead to feelings of lack of control of your thoughts or going insane or losing your mind, and also, you know, having complete, you know, surrendering yourself to the experience. There's a lot to go in here and a lot to talk about, but I don't want to overinterpret it too much because this is one single study in less than 20 people, and there's a lot more work to do, but believe me, we're working on it. Not only has this happened with psilocybin, but we followed up with a secondary analysis of data that we have, fMRI data that we have under the acute effects of salvinorin A. I mentioned it's a kappa opioid receptor agonist, that receptor is also densely expressed in the claustrum, and we see essentially some similar findings, some differences in findings. But this is really early on. We have at least 2 models now that could possibly explain some, on a circuit level in the brain, some of the acute effects of psychedelics. And these models are not necessarily mutually exclusive. They may end up explaining different aspects of the psychedelic experience, but I think it's important that we're thinking about these things on a circuit level. So I've talked an awful lot about, from brain to behavior, what the acute effects of psychedelics are, but I would argue maybe more importantly and more interesting to me are what happens after the drug effects wear off. One of the reasons that people are so excited about psychedelics is the potential that they may be able to be useful in treating mood disorders, substance use disorders, and possibly other indications. So I'll just give you a quick data blitz of the recent findings. Some of the more recent findings that kicked off a lot of the interest here were in patients who were suffering from a late-stage cancer diagnosis. And if you have ever known someone who's suffered from a late-stage cancer diagnosis, you know that the depression, the anxiety, really the existential crisis that accompanies that is just as difficult, sometimes to treat, or more difficult than the actual cancer itself. And this really goes to leading people to be debilitated in the final stages of their lives. So the reasonable question was, you know, can we use psychedelic experiences to kind of ameliorate some of that? So in this study on the left, the two panels on the left, this is a study in cancer patients that was published in 2016. Patients were randomized to receive either a high dose of psilocybin or a very low dose of psilocybin first, and then they followed up with a second session where they were crossed over. And in the red line, we see patients who were administered a high dose of psilocybin first. These scores on the Hamilton Depression and Anxiety scales are very high scores, moderate to severe depression and anxiety, and they come down to nearly remission levels after a high dose of psilocybin. You'll see that the blue lines, which are individuals who are first randomized to the very low dose of psilocybin, a trivial dose of psilocybin, they still see a substantial reduction in depression and anxiety. I would argue, and I think this is an important point, that that might represent the extra pharmacological package. So everything that goes on besides having a person consume a compound all has a lot of therapeutic potential. All of the kind of rapport building and potential unstructured psychotherapy that occurs before drug administration certainly has the potential to have an impact here. Having someone lie on a couch with eye shades and headphones and a comfy blanket is almost like a mild to moderate sensory deprivation condition itself, which could possibly have therapeutic effects. You put all these things together with, non-judgmental, compassionate human beings who are going to sit there for 8 hours. Like, when's the last time any of us have gotten the chance to just lie down for 8 hours and listen to music? Like, I want to do that right now. Not right now, maybe later, but like, so as soon as those individuals received psilocybin, they came right down to where everybody else was. That was maintained for at least 6 months afterwards. About the same time, our colleagues in London published an open label pilot study in patients with treatment-resistant depression. And briefly, these were also moderately to severely depressed individuals. And 1 week after the second of 2 psilocybin doses, most people came way down in the depression severity. What you'll notice, a couple things here is many people began to drift back up at about 3 months post-dose. And some people you could, like the green line in the middle, you might be able to consider as a non-responder. So this is not a perfect intervention, and this was an open label trial on a small number of individuals. We followed up with a study in patients with major depressive disorder writ large. It was a waitlist controlled trial. On the left, you see the average. 1 week after the second of 2 doses of psilocybin, patients were on average in remission. Over 50% of people in the trial were in remission from depression for at least a year after treatment. Over 70% of individuals in the trial exhibited a clinically significant response, which was at least 50% reduction in their depression severity from baseline. And almost everybody maintained that through at least a year after treatment. The left is the mean. The right is the real story. It's we call it a spaghetti plot, right? And what if you just kind of blur your eyes a little bit, this, each line represents one patient in the study. And you'll see that the modal response actually kind of matches the mean a bit, but importantly, some people drop down in a week and then by 3 months they pop right back up. And conspicuously, the individual at the very top in the purple line and then an individual in the middle with a pink line, there are some people who are really non-responders. We shouldn't expect this to work for everybody, and why should we? It does work seemingly for a lot of people under the conditions that we had in this study, but there's still a lot to learn about who it will and won't work for, and under what conditions and for how long. And then, questions like, well, do you have to administer it again in 3 months, 6 months, a year, ever? We don't know. We're still very early in this process. This just represents about 24 treated patients. And this year, finally, or at the end of last year, our colleagues in London published a head-to-head comparison with escitalopram. So a 6-week course of escitalopram compared to, I believe, 2 doses of psilocybin. And the careful and pre-registered outcome here, which was comparison between escitalopram and psilocybin on the quick inventory for depressive symptoms, that showed no difference in escitalopram versus psilocybin. They had a number of secondary outcomes that en masse, I believe, really speak to a favorable outcome for psilocybin over escitalopram. This was published with those findings. I really believe at the very least it's a non-inferiority finding. But again, this is 30 people in each group, so more than 24, more than we've studied before. But we still have a long way to go. But these are still really kind of encouraging results. Looking back to the prior era of psychedelic study and clinical use, there were lots and lots of studies that were published, but very few of them would meet modern criteria for rigor and reproducibility in science. What I believe it was Johansson and Krebs published in 2012, they went back and scoured the literature, found 6 papers where LSD was used to treat alcohol use disorder, and they felt that there was some control that was believable in the study. And they did a meta-analysis of these data, and this is the result. Essentially, across all studies, the meta-analytic finding was a favorable effect of LSD compared to whatever the control was, and the controls varied from placebo to some other active drug condition. More recently, our colleague at NYU, Michael Bogenschutz, demonstrated in an open label paper on the right, that 2 psilocybin drug administration sessions embedded within, I believe, a 16-week or 36-week, it wasn't that long, that he was doing motivational enhancement therapy, that he saw a significant reduction in both number of drinking days and percent heavy drinking days. My colleague at Hopkins, Matt Johnson, right about the same time published an open label pilot study in patients with people with tobacco use disorder, showing after psilocybin intervention, 12 out of the 15 individuals in the study were abstinent cigarettes, biologically verified abstinent cigarettes. This shows up to 6 months post follow-up. I believe he published a follow-up study where they went out to, I think, 11 of the individuals were biologically verified abstinent cigarettes a year and a half after treatment. And this was verified with both exhaled carbon monoxide and urinary cocaine. And just a week or two ago, Michael Bogenschutz published this result of a randomized control trial follow-up in which percent heavy drinking days, percent drinking days, and drinks per day were significantly reduced and somewhat maintained after psilocybin treatment compared to treatment with the active control diphenhydramine. Matt Johnson also has a randomized control trial that he's following up with, is, I believe, going to soon wrap up. It'll be a little longer until we see those data. But these are the therapeutic effects. These are the strongest therapeutic effects that we have with psilocybin-assisted therapy to date. We'll go into a little bit more about what else is happening in the field. I want to give you one more quick data blitz on what I think might be happening to sustain these efforts. So the circuit models of psychedelic drug effects in the brain that I showed you earlier and kind of ran through quickly only really explain what's happening acutely. They don't necessarily explain what's changing afterwards. I want to know, when you go back to getting stuck in traffic and paying your bills, what changes in your brain to maintain these rather remarkable potential therapeutic effects. Al Garcia-Romu and Matt Johnson published a survey in which they asked people who had spontaneously quit smoking after a psychedelic experience in their life, well, what happened and what was different? And one of the things they asked them was, compared to previous quit attempts, how severe were each of these symptoms related, after your psilocybin related quit success? And we see a lot of things like weight gain, increased eating, digestive problems, like a lot of physiological correlates of craving or withdrawal. Withdrawal specifically, we're no different than, on average, than previous quit attempts, but affective components of withdrawal were much less severe on average, for the psilocybin-related quit success compared to previous quit attempts. There are other literature suggesting an acute effect of psilocybin in reducing negative affect and neural correlates of negative affective processing. I demonstrated in a small pilot study of healthy individuals that compared to 1 day before psilocybin in the blue bars, amygdala reactivity to emotional facial stimuli was reduced 1 week after psilocybin administration, and these rebounded back to baseline levels 1 month after psilocybin administration. This, paired with some subjective reports of mood and affect, suggest a transient reduction in negative affect and neural correlates of negative affective processing, but a sustained increase in positive affect, self-reported positive affect after psilocybin administration. We followed up with a somewhat similar analysis in a subgroup of the patients that we treated in our randomized in our waitlist control trial. These are 14 patients in that larger group. This is a spaghetti plot for those patients. Most of these patients showed some degree of relief from the depressive symptoms. Almost all of the patients from 3 weeks before to 1 week after psilocybin therapy showed a reduction in amygdala reactivity to negative affective stimuli. And that reduction in amygdala activity was correlated modestly with antidepressant effects at 1, 4, and 12 weeks post psilocybin. This is my really kind of preliminary pitch that I believe negative affect may be a therapeutic target of psychedelics, and I believe it's possible it may be a transdiagnostic therapeutic target. Of course, negative affect and alterations in negative affective processing may be definitional in some mood disorders, but it's also a key component of the development and maintenance of certain substance use disorders. If you think about negative affect related to withdrawal and craving and the kind of cycle of addiction, if we can call it that. If psychedelics can lessen that negative affect and negative affective processing, alter it and shift it even for a week or two, that may give someone kind of the room they need to begin to get on a better trajectory for healing. Peak experiences seem to be significantly correlated with ratings and the meaningfulness and the spiritual significance of psychedelic experiences in healthy people. And we like to point out that a lot of participants, when asked the question, will rate their psychedelic experience as among the top 5 or single most personally meaningful and spiritually significant experiences of their entire lives. These experiences may also be correlated with therapeutic outcomes in our cancer patients, in our individuals treated for tobacco use disorder, with mystical experience being correlated with change in craving, confidence to abstain, and temptation to smoke. But it may be that these mystical experiences are really, and acute insights are really predicting or leading to a change in psychological flexibility that may also predict therapeutic effects. In our patients treated for depression, we demonstrated, this is a really busy slide and I only have a couple minutes left, so take my word for it. We can walk through it later if you have any questions, but we see an increase in cognitive flexibility that's also associated with an increase in neural flexibility, and both of those are correlated with antidepressant effects of psilocybin in the same sample that I showed you before. May I make the quick pitch that cognitive flexibility may also be a transdiagnostic process or transdiagnostic therapeutic target of psychedelic drugs. Everything I've showed you so far has been in humans, but there's an increasing amount of animal model evidence to suggest that psychedelics of various forms, not just classic psychedelics, may essentially enhance or lead to increased plasticity in the brain, especially in prefrontal cortex neurons. These are neurons that may have shown some kind of disease progression or reduced kind of synaptic availability, or with increased spine growth and synaptogenesis, you may be able to find some kind of molecular explanation for some of the therapeutic effects that we've seen. And just to close, it may not all be serotonin 2A mediated. These are data from Hesselgrave, University of Maryland. In animal models, she basically showed that when you block the serotonin 2A receptor signaling, but you otherwise administer psilocybin to rodents who have essentially gone through a number of different stress models to then exhibit anhedonic and depressive-like behavior, that you see a recovery of this behavior even without serotonin 2A receptor signaling. I want to just end on the second final note, which is, lots of things are happening now. We're not just looking at, we as a field, we're not just looking at mood disorders and substance use disorders. We're not just looking at smoking and drinking. We have ongoing studies in those. I'm running a study in depression with co-occurring alcohol use disorder. Matt Johnson's following up with a large multi-center trial for smoking cessation. We're doing a study in opioid use disorder, cannabis use disorder, now obsessive compulsive disorder, anorexia, mood and cognition, and Alzheimer's dementia, PTSD, post-treatment Lyme disease syndrome. What's next? Gout? I don't know. But we're not the only ones in this space. Lots of people are looking at complex trauma, PTSD. Lots of other sites and lots of other research centers in the world are doing this. And I just have to take a moment to say that I don't think we should see these compounds and these approaches as panacea. They're almost certainly not going to work for everything. And we need to be really careful in tempering our enthusiasm, because even the data that I've shown you so far is early stage in terms of what is necessary to get a drug through the approval process as a medicine. But of course, this is exciting. I think it's important to map the edges of the indication space and better understand who these drugs will and won't be safe for, under what conditions, for how long, and really there's so much work to be done. And the final one slide is just acknowledging the really amazing multiple teams of individuals who I have the privilege of working with, and without whom none of this would occur. So thank you so much for your attention.